A 72-year-old farmer presented to us with a long-standing growth over the right cheek, and we straight on proceed to the excision. We did this under general anesthesia. For a proven basal cell carcinoma, this case was proven to be a basal cell carcinoma in punch biopsy. So for a proven basal cell carcinoma, we have to take a margin of 0.5 centimeter to maximum 1 centimeter. Here you can see the post excision defect, and we have marked the proposed flap which we will close the defect with. So we have taken a rhomboid flap and we will be trying to cover the defect with a transposition flap. So this flap is also called as Limberg flap, and since the defect was a circular one, we had to remove the margin of the posterior superior part of the area to fashion it into a straighter incision. I am trying to get into the subcutaneous plane and take a thick flap with a intact blood supply, which it is getting from a random supply from the superior aspect, and I am trying to close in, and I will be taking out the flap at the depth of the fatty layer of the cheek. So I am trying to buzz off small vessels from the bed of the elevated flap area, and carefully we can see the plane of dissection. It is just above the level of the masseter muscle, to the depth of the level of the masseter muscle, the fat covering the masseter muscle and also the fatty layer of the cheek. So now you can see that I am trying to pull the flap into the defect, and it is quite a treacherous area because the defect has some part over the dorsum of nose also, and as I tried to cover the flap, I have found that it is still inadequate to cover the dorsum of the lateral aspect of the dorsum of nose. So I had to release a few more millimeters. Now I think it is adequately covering the defect. So our aim would be to first cover the defect and later on suture the donor area with a primary intention as far as possible. So here I have started approximating the flap with some stay sutures, putting at the pivot points of the flap and the defect. You have seen that I changed my gloves. Also my assistant had changed the gloves. So this is a standard procedure we follow after we have harvested the flap. Before closure, we usually clean the wound as well as we change our scrub sterile gloves so as to avoid any sort of contamination. So I am doing the tacking sutures to close the defect and bring the flap closer to the defect, and the fine suturing will be done further. So I'll fast forward it. So there is a complicated triangular defect which has to be sutured. So this is posing some kind of worry what has to be done. So what we did is we have first undermined the deeper tissue beyond the margin of the flap so as to bring the margins closer for suturing. So you can clearly see the plane of dissection, that is in the subcutaneous plane, just at the fat plane, just above the fat and masseter muscle. So the suturing will be done from the periphery towards the center, but the inferior edge, as you can see, there will be one dog earring formation. So I was thinking to extend the incision downwards, but again the whole thing of this suturing the gap and the plastic repair of the face, it is a tailor-made approach which is often decided on table. So the decision of extending the incision I aborted, but I then proceeded with suturing from the lateral aspect of the defect and closing the gap as much as possible, and then further to decide the remnant gap, whatever is left. So that's what I thought, and I started doing the suturing. And keep watching, so you will know what I had done for the dog ear. So as I was telling that there was a dog ear formation. So how I got rid of that is by taking out this Burroughs triangle. This is called a Burroughs triangle. I have removed a wedge shaped chunk of tissue from the edge of the line to be sutured, and this dog ear or protruded portion, this defect can be averted by taking out this triangular chunk of tissue from one of the edges of the flap. So after that, once you suture, you will see that it is beautifully approximated without any bulge over the corner, which is called dog ear. So this can be done in multiple instances also, when there is a tissue loss due to a trauma of face. There sometimes you might, while suturing, you might see that there is a formation of dog ear. That can be got rid by taking out a triangular piece of tissue from one of the edges of the corner. So this is how I finished all the suturing, and I'll be closing it down. And I have not put any drain inside because it was very well, hemostasis was achieved very well. But if you feel, you could put a Penrose drain or a glove drain through the incision side, so as to drain off any collections which is gathering underneath. And this patient healed up very well, and I'll show you the pictures of post-operative pictures, and you'll see how it healed well. Only thing was that there is some post-operative edema present over the cheek, supposedly due to I think the lymphedema. So here are some happy faces of the assistants and the anesthesiologists. So here you can see the pre-operative and post-operative photographs simultaneously placed together, and this is a 3-week post-op image where you can see some edema is there. And this is our team. Thank you.